Hello, everyone, and welcome. My name is Corey Thornton. I'm the Managing Editor for Market Intelligence at Open Minds. Today, as part of our weekly Executive Web Forum series, Open Minds Senior Associate Cathy Gilbert will discuss developing behavioral health centers of excellence. Ms. Gilbert brings over 20 years of experience in the healthcare industry, including with nonprofits, government, private insurance, and provider networks. Before we get started, I have some housekeeping reminders. Your audio will be muted for today, but we also rely on your questions and comments via the question box on the right side of your screen. You can send in your questions throughout the briefing, and Ms. Gilbert will answer them during the Q&A session at the end. The slides and recording for today's briefing will be available on the Open Minds website starting tomorrow. And with that, Cathy Gilbert, and I will set up the slideshow momentarily.
Okay. Okay, there we go. There we go. Hello, everybody. Happy to be here today to talk about behavioral health centers of excellence. It is something I've worked on in a couple areas as I've in my experience with both Magellan and Value Options. So, Corey, my screen is not moving. Trying to move the slides, Corey, and they're not going.
Okay, try it now with your arrow keys.
That's what I'm using. Okay. Oh, now too fast. There we go. Okay. So today I want to cover a few areas. First, just defining a center of excellence, talk about how payers design centers of excellence, and how you determine if you're ready to be a center of excellence, and kind of what's the process with different plans. So I'll try to go through this not too quickly, but so that we can all have a discussion and I can answer questions at the end. So, as Corey already indicated, this just tells you a little bit of my background. My background in the managed care world has been primarily with Value Options, then Beacon and Magellan, working in the provider network arena. And prior to going to the managed care world, I worked in community mental health centers and actually ran a small nonprofit with intermediate care facilities. So background in this arena for a long period of time. So to start out, what really is a center of excellence? We see center of excellence designations across industries. We hear about Good Housekeeping Seal of Approval. You see the J.D. Powers Awards. You look for approval by the Better Business Bureau. Those types of things that designate quality and best in class type of service across in an industry. And Wikipedia defines it as a shared facility or entity that provides leadership, best practices, research support, and or training for a focus area. But it's pretty vague in broad usage, and it can have slightly different meanings in different industries. So in healthcare, a center of excellence typically it's a provider organization, or it could be a provider group. It could be sometimes an individual provider that's a preferred provider, but they are assembled to supply a really high concentration of expertise and resources centered in a particular area of medicine. So in behavioral health, it could be something in substance abuse with a specific diagnostic category, or some kind of a comprehensive program. They really look for whole person care, and with the goal ultimately to having the best patient outcomes for that particular diagnostic category or service. So again, that key word there is outcomes. That's really what health plans are looking for, and health plans kind of identify positive outcomes. So say lower recidivism rate, somebody spending more time in the community versus the hospital or an inpatient setting. Outcomes also lead to cost savings. So it's a combination of things that plans are looking for when they're thinking of centers of excellence. Come on. So, and there it goes. So today, what do centers of excellence look like in healthcare? In general, you hear about the Mayo Clinic, the Cleveland Clinic, Johns Hopkins. In any state in the country, there's probably their university health system for the major universities in that particular state. In behavioral health, things like Hazelden, Betty Ford, some of the different eating disorder treatment programs, Shepherd Pratt or McLean, that have well-known programs in different areas, that just ones that you hear of and are known in the industry. The types of programs that they look at are to design centers of excellence from a plan are high cost diagnostic categories. So I mentioned eating disorders, high volume diagnostic categories. We're seeing substance use disorder treatment, depression, treatment of depression. So high volume type of diagnostic categories. Complex conditions or dual diagnosis. So individuals that may be dually diagnosed with a substance use and a mental health disorder. Those kinds of things are what plans really look for centers of excellence for treatment for that person, for best in class. So that's what to think about. It's not all just level of care, it's the type of condition and outcomes in treating a particular condition or diagnostic category. So when we talk about the design that payers look at, what kind of data, what they look at, they start with their preferred provider networks. And most payers nowadays have some sort of a preferred provider network or a preferred provider designation that they use when for providers. It could be for facilities, which is their higher levels of care and specialized diagnostic categories. It could be from specific clinicians, groups, or outpatient services. They look for evidence-based practice and outcomes as compared to similar practices. And plans are working on developing, there may be provider scorecards, but those are the things that they look at, and they look for those performance-based outcomes to partner with the various providers. So it starts with that preferred provider network and those criteria. Then they build the behavioral health centers of excellence. It's usually a small subset of the preferred networks. They're the highest performing partners to the plan for specific diagnostic categories or programs. And they look for both clinical and administrative performance. So they even may include things about you do things through their web portals, that you have low denials, that you really do manage the medical necessity criteria in the clinical program. So they're looking clinically, quality, administratively. And in some cases, depending on the client, benefit plans for members are adjusted if they're receiving treatment at a center of excellence. They may have a lower out-of-pocket cost, and that they may have an opportunity. Some plans may have members who are not always in the regions where a full range of services are available, but if a member, they may pay travel costs in some way for a member to receive care at a center of excellence under certain conditions, not always. But those are different types of things that are a benefit to the member and to the provider. So you might get some different people from outside of your local catchment area. So where do they start? They design it in clinical and quality. They look at specific diagnostic categories. The most common ones I've seen and what I worked with was related, especially with the opioid crisis in this country, substance use disorders and opioid treatment facilities. They may be specific age groups. So for example, adolescents and eating disorders might be one. Level of care, they look at them for different levels of care. Now, a provider organization doesn't have to have all levels of care, but you could be a center of excellence for a specific level of care, such as inpatient residential, partial hospital program, intensive outpatient programs. They're looking for those outcomes, and they look for partial hospitalization and intensive outpatient programs in a local community, potentially as a diversion from inpatient or higher levels of care. So strong programs in those categories are things that plans look for. They also tie tightly to quality metrics, especially HEDIS, because that's critical to plans, and then clinical and administrative. So they'll look at average length of stay. And with that average length of stay, in combination with that, they're going to look at readmit rates, target initially at 30-day readmit rates, and then farther out, 60, 90-day readmit rates as well. They will look for care coordination. That means if the program that's in their Center of Excellence program with you is, say, an inpatient level of care, they're going to really look for that care coordination and transition to assure that that member is connected with care post-treatment, post-inpatient stay, to get their follow-up and maintain in the community and maintain in a path to recovery. And then they're also going to look for compliance with authorization and billing processes, some of those administrative functions. Payer, just like providers, payers, they want things to go smoothly. They want, authorizations to be obtained. They want claims to auto adjudicate. They don't want to have to do those manual administrative interventions. That increases their cost just like it increases a cost for a provider. So the goal is that's compliant with all those processes so that all of their automation works and that but you talk when you need to. But that's an important piece for plans that providers really work within their system so they don't have a lot of one-offs, even with a Center of Excellence. And a question that always comes up with providers is, what do payers look at on payment arrangements? Now, some of the Centers of Excellence designation don't carry a different payment arrangement, but it's definitely something you can negotiate. So it could be an enhanced fee-for-service fee schedule. I've seen programs where they say, okay, as long as you continue to meet this criteria, this is your standard fee schedule, which is higher than their standard outpatient fee schedule. If you don't meet the established metrics, then you revert back to their standard fee schedule. So they could be an enhanced fee-for-service. It could be a value-based payment type of arrangement. They would look at, a case rate or a bonus payment if you continue to meet certain metrics that are expected for for a Center of Excellence or a preferred provider. And you should be kept up to date on those from the payer perspective, but also have your own data. So who has these programs? I said earlier, most plans have some sort of a preferred provider type of setup. And it's a couple of examples. A national program is the Blues Program of Distinction. It's under the Blue Cross Blue Shield Association. And but you have to be invited by a local plan. So wherever you are, if you're participating with Blue Cross Blue Shield and our Center of Excellence, they see your local plan sees you as a Center of Excellence. They can invite you to apply to be a Center of Excellence under the Blue Cross Blue Shield Association. Now, this was just implemented for behavioral health / substance abuse in 2020. So it's fairly new in the behavioral health arena for the Blues Association. Currently, it is only for substance abuse treatment services, and there's a process. It's an application, invited by a local plan. You complete an online survey, and then there's an application and an evaluation process using the Blue Cross Blue Shield claims data and Blue Cross Blue Shield's brands criteria. So that's a national program. You can get the designation, but it's not tied to your agreement. That would be up to negotiating with your local Blues plan. Optum has the ACE program and the Platinum program. The Achievements in Clinical Excellence is for the clinicians, so that would be group practices, outpatient services. And then the Platinum designation with Optum is for facilities. And both of these programs are published Optum's is on their website. The Blues Association, they have some information on the Blues Association website. It's also, I know the regional blues plans have information on their websites. I'm based in Michigan, so I looked at Blue Cross Blue Shield of Michigan and was able to find the application and all the information on that program right on their website. I also know that some plans outline these programs in their provider handbook. I believe Molina has a preferred provider type program outlined in their website. Other payers do as well. But those are just to give a couple examples of plans that have these types of programs. So what are the benefits of being a center of excellence or a preferred provider? One is recognition. So plans do show these providers in their provider directories, both online and if they still produce paper directories on occasion, there's usually a designation that shows in the directory, recognizing facilities or providers that have met these standards. A lot of times they have a streamlined clinical review process. For example, on a higher level of care, you may have to notify of admission and give an initial review, and then they authorize, a longer number of days, and it's up to you to manage the care and notify them upon discharge, so that they streamline that process for less intervention. Or you may have reviews less frequently. They may give you one program that I worked with is they authorized for any provider their average length of stay up front. And then it was up to you to manage to try to maintain a target on length of stay with the outcomes or, decreased recidivism, those types of things. Also, it could mean increased referrals because you're a partner with that plan. The care managers and the clinical team know you. They may make referrals directly to the program more often because they know the quality of the program and are more familiar with it in that partnership. The other reason is that designation in a provider directory. Members using a provider directory may look for providers with that specific designation. And then there is the opportunity for enhanced reimbursement rates for meeting or exceeding established metrics. Those are going to be negotiated by each individual provider for their contract, but those metrics are a good starting point for supporting enhanced reimbursement rates. So the next thing in looking at a COE is, am I ready to be a COE? What does it take? So one of the things that's really key to being a center of excellence is knowing your data. And at the granular level, you're going to need to look overall at how the quality of your program, but also be able to break out your data by payer and by plan within a payer. For example, a commercial employer group covered employee versus a public program, Medicaid, Medicare, or an exchange on the marketplace or exchange programs through the Affordable Care Act. So it's really important to have that data and build your own story. The plans are going to bring their data, what they see based on claims, authorizations, et cetera, on the performance of your organization. But you should always have your own data to compare to the plan's data to make sure, because you want to make sure all of the data is accurate. So that's really knowing your data and being able to run your own data on your average length of stay, your recidivism rates for ones, and you may not know members admitted to other facilities, but you'll know who comes back to your facility. And a lot of times payers, for example, on recidivism, they know where a member has had care, and they do try to refer members back to the same place if appropriate for treatment, if they have a need for continuity of care and knowledge of the member. But it's important to be able to do that. Follow up after hospitalization. Do you make sure that the member has an appointment, and being able to track for yourself that, hey, we scheduled these appointments with this member upon discharge from inpatient, so that you have the documentation and the data. Then you can identify payers who have programs that payers that you participate with that have these programs, and then you can identify new targets. But what you want to make sure is that you have the data available. The second part is looking at your relationship with the payer. Make sure they know about your outcomes and that you're a partner. Don't be afraid to ask about, hey, do you have a preferred provider program? Do you have a center of excellence program that we might be an appropriate fit for? Highlight your outcomes and your success stories. Payers may not always see that. They have large networks, so you have to it's a marketing of yourself and your successes. It can often be driven by volume. So payers will look at their highest volume providers, or where they may have an outlier, or because somebody there knows a provider well for whatever relationship reason. But also, even if you only see 10 patients a year for a particular plan, that can qualify you for consideration as a center of excellence. So volume's important, but it doesn't have to be a huge volume to qualify, depending on the diagnostic category and the services. And the metrics you would be looking at for under a COA are similar to metrics that you might be looking at under a value-based payment arrangement. So those arrangements are often tied to HEDIS measures, quality outcome measures, things that are very much industry standard. So when you want to become a COE program, it's important to have internal quality monitoring program to demonstrate your outcomes, to demonstrate clinical effectiveness, member access to care, member satisfaction, and administrative efficiency, and for those to be monitored. A lot of the Center of Excellence programs and data within the plan will be monitored through the quality and compliance department and looking at outcomes and data that the plan has. So they're going to look at, your average length of stay, recidivism, on an outpatient side, can a member get an appointment within 7 to 10 days of contact for an initial appointment? On ambulatory follow-up after an inpatient stay, can a member get into care with that outpatient provider within 7 days? Or did the inpatient facility get an appointment scheduled, communicate it to the member, and let the plan know that, hey, we scheduled this appointment, and the plan will do some follow-up with the member as well to try to make sure they get to that appointment. I also that you have satisfaction surveys, member patient satisfaction surveys, and act on any issues that might be identified from those. Administrative efficiency, I already mentioned, that's related to using a lot of the automated programs that plans now have, including electronic claims submission, electronic payments, their online authorization portals. All of those things are what plans are going to be looking for, but monitoring to make sure those things are happening within your organization, having a quality program. One program I worked with looking at centers of excellence, we actually looked for the quality policies and how the provider monitored for quality outcomes and clinical effectiveness within their organization. Plans will obviously want centers of excellence to be accredited by a national accrediting body, be that JACO, COA, CARF. They will look for that. And then they will look for use of evidence-based practices and national standards. The SAMHSA standard, Shatterproof is coming the latest, ASAM criteria, but they will look for, truly look for those evidence-based practices. So the next thing you might ask is, what levels of care or the care continuum, what programs do I include? If you have full continuum of care, you can include all levels of care. Plans may look at it specific to location and level of care. For example, the Blues Program of Distinction, it is specific to a location and a level of care. They look at each one individually for the designation. That's one example. They will look at inpatient, residential, partial, intensive outpatient, outpatient services, and crisis services. You don't have to have all levels of care, but they will look at a full continuum, and it could be, vary based on if you're serving members in a local area where members could come back to you for outpatient services because it's in their local community or within a reasonable distance, or it could be that you have one level of care. If members travel, that you have a process for coordinating to assure they're connected and getting care upon return to their local community if it's not feasible for them to continue in aftercare with your program, or if that's not part of your continuum of care. You don't have to have them all, but you have to be able to coordinate care. Collaboration to meet the member needs will be a key part of the program. You need to really have that collaboration, some aftercare services, case management type functions to assure that all of those needs are being met, regardless of the level of care that's within the COE. So in thinking about all this, are there costs to becoming a center of excellence? You have to identify what you already have and what you may need to add or enhance. So a robust EHR with reporting capabilities. You may need to look at what reports you have available, or if you're using your EHR to its full capability. The EHR systems I see now have a ton of information. They're very capable of collecting a lot of data, but you have to make sure you have the appropriate modules and reports set up to manage and understand what's happening. And monitor. So for centers of excellence, for example, a program, I mentioned earlier, they may ease the administrative and authorization requirements, but they're going to still expect you to manage your own length of stay. So you need to be monitoring through reporting, just like health plans do, length of stay and what's going on with cases, and making sure your length of stay, they'll monitor, knowing that you have some cases that are going to have shorter lengths of stay, some that are going to have longer, but they're going to want to have a target usually of a certain average length of stay. And you need to be able to monitor that as well, both at the individual plan level and overall. So those reporting capabilities around any of the metrics that you might be agreeing to under a Center of Excellence program or as a requirement of a Center of Excellence program. It's really important to look at that ahead of time and know if you have the reporting capabilities or if those need to be developed. Do you have a quality program? How is your quality program run and monitored? That may be just, what is the process, having the policies and procedures. Most organizations do, but it's looking at them to make sure they incorporate some of the requirements that a plan may have for their Center of Excellence. So they usually publish descriptions. There's conversations with the plan around what the expectation is of a Center of Excellence, what they want you to do. And then you need to think about all of those things and make sure your policies cover it and your procedures as in your monitoring for those metrics and maintaining those outcomes. And then I mentioned earlier, sometimes with Centers of Excellence, patients or members actually travel to receive a specific service at a Center of Excellence. So it's being able to collaborate beyond your local area. If you're located and the member travels from a next state over, or even a little bit out of the area. So maybe it's your local residential or inpatient program is, 50 to 100 miles from where the member is. It still might be in the same state, but they're not going to be able to necessarily travel for outpatient follow-up services. So how is that collaboration going to happen with either connecting them with a local provider back closer to their home, or are you in today's world utilizing virtual care and telehealth services to continue to meet that member's needs if that's appropriate? So it's to think about all of those things that you might need to offer or have available to make sure that you can meet all the needs and maintain the requirements of becoming of a COE. So what is the application process? And I've referenced this a couple times, but it's step by step. You will have to look at each plan and identify the specific process and requirements. You may want to request data from the plans, and the plans, when you want to ask them about this, you may mention to them, hey, I'd really like to see what you have on our on our performance. If they aren't sending you some kind of a provider report or scorecard type of thing that gives you your data. And then review any reports from the plan in detail and ask questions. That's where it's important to have your own data so that you can see if the data they're sharing with you aligns with what you believe your performance is. You want to call out any discrepancies and have a discussion with the plan. There may be things that are impacting that data. So it's really important to take a look at that. And then you may develop kind of a pitch deck with the plan when you want to talk about the application process or becoming a COE. So you want to include in that pitch deck, hey, this is all remind them of all the services that you offer. Include your data and outcomes, your overall performance, and then your outcomes specific to the plan that you're applying to be a COE. So you need to be able to pull that data and really market to those plans, and to talk about how your outcomes and your performance. You want to become their go-to provider and ask how you can help them. Say, hey, if I'm your go-to provider, I'm your center of excellence, even if it's in this region, here's what I can do for you. I can guarantee we get your members in. Our outcomes demonstrates our clinical effectiveness, that we're able to treat members in, say, an inpatient setting in a shorter length of time because of our clinical effectiveness. And we've been successfully connecting your members with outpatient services, so we're not seeing them come back into the care. So those are the kinds of things that are really important to talk to the plan. Big plan pain points are access to care, appointment availability, follow-up after hospitalization, making sure, looking at HEDIS metrics. Those are key to plans. An example, back in earlier this year, Hazel and Betty Ford presented at our Performance Management Institute about how they became a COE for many payers. And a lot of the things I've described are the same things I've talked to my colleagues at Hazel and Betty Ford about, how they build that relationship with plans and what they do. So then you're accepted as a center of excellence. So what's next? So it's critical to maintain that relationship with payers. It's not, oh great, I got the designation, got the contract, we're off and running. It's important to ask the payers, hey, we'd really like to have, in the initial time frame, maybe a monthly, just quick touch base on how things are going and asking questions. The longer you're in a program and as long as things are going well, those space of meetings could be stretched to maybe quarterly. But I think it's really critical to maintain that relationship and partnership with the plan. So you may have a formal meeting once a month or once a quarter, but you should have somebody who's kind of your own payer relations person who can begin to just do a outreach phone call to your primary contact. Hey, or how are things going? So that you maintain that relationship on a regular basis. It's also critical to communicate with the plan on any new successes and challenges. So some of those things, anything that changes, if you're having challenges with any area of the COE or in general with the plan, get in front of those. And then any new successes, as you get new outcomes data or new successes or positive results, share those with the plan. Also identify, even within, talk to the plan about continuous improvement and innovation. Talk to the plan about new ideas and partnering with them on something that might be new and could be of a real benefit to them. I know one thing that's come up with COVID, and I've seen some, is the virtual intensive outpatient programs. I don't know if it's going to continue, but looking for innovative programs that will help the plans, help their members, and you help their members. And it could be something where you incorporate other services, continuous improvement, social determinants of health, or is a big ticket item right now. So what you can incorporate and innovate with the plan to help better meet member needs is really, really critical, important to keep that open. And, oops. Come on. Okay, and now I can turn it over for questions.
Thanks, Cathy. I'm cleaning up my desktop briefly here. I have a few questions for you. The first one being, how will being a COE impact the reimbursement rates a provider organization could expect within their plans?
If you're a COE with one plan, that could be something you could use in your negotiations with another plan. It's also something that you use in your negotiations with that plan. So it should result in you being able to negotiate some higher reimbursement from the plan, or a value-based arrangement where there's bonuses for meeting those metrics. Some plans actually on the outpatient side may have a higher fee schedule for providers that are in their in kind of preferred or designated network for specific areas, that by continuing to meet metrics, you get a slightly higher reimbursement rate. So it's important to ask. It should be something that can be leveraged to increase reimbursement.
Thank you. And do plans ever take providers off of a COE program after they put in all the work to get into the program? How would that work? What's the risk that they could lose that status?
There is a risk of losing that status if you don't continue to meet the outcomes and the measures. But you should be monitoring that ongoing. It shouldn't come as a surprise. It should be a conversation with the plan. Plans, once they give that designation and have it publicly out there, they aren't going to take it off for no reason. So you should have been having conversations with that plan. That's where that relationship comes into play. So it gets to a point where or you've agreed with the plan that, hey, we can't meet this right now. We understand that we're going to not have that designation, but you really need to have that ongoing conversation with the plan. But yes, they will remove the designation if there is a reason to believe the provider's not meeting the quality standards that they want as a center of excellence. So it's important to monitor all of those things. It even comes back to, they look for accreditation. If your accreditation scores at a site for your accreditation renewal, and there's something found, and your accreditation is at a lower level or something, that may make the plans question, should we continue to have this program as a center of excellence? So it's really critical to ongoing monitor all of your quality metrics, because they're going to look at that. Because if they're giving that designation and it's in their provider directory and they're referring people to you, they feel like that there's a trust there between the two of you. If you're not meeting your end of the bargain and the quality that is expected based on what you agreed on for that program isn't there, they will seriously consider removing that designation.
You were talking about sharing performance metrics. What's the best way to go about that? Is it very similar to any other pay relationship where you're going to set those metrics ahead of time? Mm-hmm. And if so, who are you delivering those to? What kind of investments can make that process as successful as possible?
Yeah, those metrics are probably, you'll want to deliver definitely on the metrics that you've agreed on in your COE agreement or your value-based purchasing agreement, preferred provider network. You're going to run a report on those metrics that are important to the plan. But if there are other metrics that you have that show the quality of your program that maybe aren't something contractual, but can also support all of the work that you're doing, it's important to share that with the plan. You can share it in different ways. It can be through a relationship with an individual you have at the plan that you regularly communicate with, and you send over, maybe a short PowerPoint deck that's just a couple slides that gives, hey, here's the updates on our performance. This is our latest data. Just thought you'd like to see it, keeping that open communication. It could be a more formal presentation if you're having, say, the quarterly meetings or monthly meetings that I mentioned, where you actually present your data, say, hey, I'd like to share this. Your target audiences for that data could be, depending on who your relationships are with and the size of the plan, it could be a clinical director, a regionally based clinical director, it could be a medical director, depending on the plan, or regional medical director. For larger plans, depending on the size of the organization, it could be even the CMO, the chief medical officer for the plan, especially in some of the regional plans. Definitely want to include your provider network contact. Hopefully you would have not just a provider relations representative, but you might also have a relationship with a manager or director in the provider network department, because they can be your advocate within a provider organization. Provider network staff really are, they see themselves in two ways. And one of the big roles they see, and what I saw as the role of my team, is being the advocate for providers within the plan. So sharing that with your provider network representatives is also very helpful. So those are some of your target people, but you can have a group of contacts at any plan that you share it with. Even plans, if you share that information in your provider newsletter or in your own organizational newsletter, you can make sure that your contacts at the plans are on your newsletter distribution list if it's an email list. So especially so that they get that information and your information is in front of them on a regular basis.
Okay. So how long a process is this? How long a process we've seen strategic planning, the time available is shortened up. Many organizations are looking at their strategic plans annually at this point, sometimes quarterly. I've heard some horror stories. Now, how long does it take to invest in this? How long to get it up and running? And then, how long can an organization expect to reap the benefits of this kind of transition?
Well, I would say to get this type of thing up and running, it really starts when you initially contract with or join a network with a provider or with a payer organization, but it can start at any point. But it will take, depending on the payer and where they are in developing their Center of Excellence program. So I've been in one organization where we decided we were doing a Center of Excellence type program, and we identified we were doing substance use disorder and eating disorders, just for those two categories to start, and higher levels of care. So we identified the facilities and outreached from our data. The facilities had a chance to come back with their data. It was a discussion, and I think we identified those facilities. It's a 6 to 9 month process when you're working through that, especially if there's a contract negotiation. We all know payer contract negotiations can either be really fast or really drawn out, depending on the payer and what's going on. So, but yeah, it takes a little while depending on where the payer is in their process. Now, if it's an established application process, it can go much quicker, and it could happen within a couple months that you could work through. If you have your data in order and can make your case, they could do it fairly quickly. I know that the Blues, for example, programs of distinction, I think they actually open that up and they do those designations annually. So you may apply and be recommended by your local Blues plans, and then they do their designations, I believe, annually. So, and plans often may decide that, hey, we're only adding new providers once a year, but you want to start that conversation so that when they're adding their new providers to that designation, that you're in that mix.
So that sounds good. Now, do you think most organizations are going to be able to do this in-house today, or should they invest in a different staffing, different departments, different professionals, bring in outside third-party help?
I think sometimes some outside third party help can help you take a look at it, but a lot of it is just making sure you're organizing your data. You may be already doing all these things. If you're an accredited organization where you're doing all of these services, for the most part, you should have a lot of these policies and procedures and things in place. It's a matter of putting in the monitoring structure and reporting to really look at your own data. I mean, I've talked to provider organizations like, well, yeah, we do all of that. And I said, but plans are going to want to say, show me the data. And that's what you need to start looking at is, do you have the data to demonstrate your outcomes? And it has to be, and it can't be subjective data. You need to be being able to look at running reports out of your EHR on your length of stay, doing the breakouts, knowing your payers and their requirements. So those are the things. It could come out under your current staff. It may fit in one of those roles, but you also may want to, if you don't have somebody who's specifically your payer relations arena, that might be something to think about, or somebody in a quality type of position to help monitor all of the data and outcomes, and then looking at your reporting. So it depends on your structure. And
now, do the organizations have leverage to convince plans that their data shows excellence? Is this a predetermined thing, or is it all up for grabs? If I can prove it, it's true.
I think it's a combination. You want to have your data and not just rely on the plan's data. But yes, you have to sell yourself if they have a program, or wanting to become that payer's partner and go to in a certain market, so that if they don't have a center of excellence program, but they decide to develop one, that you're who they think of. So it depends on where the payer is at.
Okay.
Like I said, a lot of the national players have some sort of a program. So you want to ask about it and say, hey, how do I become a part of this? And what are they seeing? And if their data, and that's where you would get their data, and you want to be able to have your own data just in case something is going on that their data doesn't seem to match what you're seeing in your program. So you want to look at that, and that also gives you a clue as to what metrics they're looking at too.
Okay, that sounds very important for, and this leads me to my last question. That's payer marketing. Mm-hmm. Does having a COE designation open up your entire marketing department to selling this to the consumer, to convincing stakeholders that this feather in my cap does in fact say that we are a center of excellence and you should bring your business to us?
In some cases, yes, you have to look at your plan agreement, your agreement with the plan, and that's a question to ask them. Hey, once we have this designation in your directory, is it okay if I publish this? Most plans will say yes, as long as it matches their directory, because they're publicly putting it out there. I know I have seen on LinkedIn even announcements where a provider organization says, hey, we just got approved. We are now a Blues program of distinction for substance use treatment at this location. So yes, I think in most cases, once you have that, plans will let you use that in your marketing, but always ask and look at your provider contracts, because provider contracts often say you can only use our name in certain ways, and just make sure you get a sign off, or they'll let you publish it, but they want to make sure you have their logo right and their colors right if you're publishing it on their website, that kind of thing. So it's always good to ask, but typically they will allow it.
Okay, well, thank you, Cathy. Before I do my wrap up, is there any parting words of advice you would like our attendees and video viewers to know about this?
No, I think it's really important. I know there's a lot of good providers out there, and I would love to see more of them get the recognition for the work they do.
Okay. Well, thank you very much. I want to thank everybody for joining us for today's web forum, and remind everybody that the slides and recording for this will be available tomorrow on the Open Minds website. We're also back next Thursday for the Executive Web Forum, Best Practices for Moving Your Organization to Data-Driven Decision-Making, the I Am Boundless case study. That features Jennifer Reha, Vice President of Performance and Improvement and Service Delivery, and I Am Boundless. That starts at 1 p.m. Eastern. You can sign up at www.openminds.com. It's listed under the webinars in the events tab. With that, thank you again, Cathy.
You're welcome. Have a good day, everyone.